Good morning. This is Steve Stites, Chief Medical Officer. Let me try that again. Chief Medical Officer at the University of Kansas Health System. We're broadcasting live from the Dolph Simons family studio here at our health system. I have two new guests, but don't worry, Dr. Hawkeye is still out there. Dr. Hawk, as we've now just heard you be called, you doing okay today? Hawkeye.
Close by.
All right, good deal. I am joined on my right, Tammy Peterman is our president and the chief operating officer of the health system and president of the University of Kansas Hospital on the Kansas City campus. Bob Page is CEO of our health system. They are here this morning. We wanted to talk a little bit about safety in a hospital and at large. And I think that's really going to become an important topic as we start to open up our society. Let me first turn to Tammy. Tammy, you know that we're safe. You work so hard at patient safety every day.
Well, you know, Steve, I think that's part of what every hospital tries to do every single day. Even before all of this, we know that we came to work to make sure that we are providing the safest environment for every patient who came into our hospital. Now, we have a little bit of a new normal right now, and we know that, and there won't be a switch that gets flipped really quickly. We know that. This will be a gradual process to bring additional patients back into every hospital across the area. We also know that every hospital in Kansas City right now is taking care of a lot of patients. I think we have about 500 patients on this campus on the inpatient side. So we know how to be safe, and we can do this. We know that we can. Our nurses, our physicians, our therapists, they work at this every day, and they always have worked at this. Now, do we have some additional processes in place? Sure. We're going to screen everyone, as we have been when they come into the hospital, and we have screeners all over our campus making sure that people are being screened when they come in. Will we do some additional testing? Sure. We'll do that as well. Will we make sure that we are socially distancing? Yes. We have teams in place who are helping to monitor that and make sure that we are keeping that social distance. Are we monitoring our PPE every day? Yeah, we are. So a lot of things are in place. And just as we have prepared for and continue to prepare for taking care of the COVID patients, we also had to prepare to bring patients into our organization who needed care. We know that we put some of that care on pause, and some of those patients need to get back into the health system.
That is so important. And this health system, Bob, has always put the patients at the center of every discussion we've ever had.
We have, Steve. The other thing we've done is we put our staff at the center of everything. And I want to spend just a minute to talk about what we're doing about our staff. So I think it's fair to say over the course of the last 4 weeks, there probably hasn't been a day go by where we all haven't gotten some kind of article, news briefing about layoffs, furloughs happening locally, regionally, nationally, internationally. And those are incredibly hard decisions to make. Tammy and I have had the opportunity over the last 21 years to talk about the transformation of our health system. And people ask us routinely, so what's been the secret to the transformation? And the answer is really simple. It's people. And we have committed to our staff for the last 21 years. We've had no layoffs. We've had no furloughs over the last 21 years. And it is not our intent to do that now either. So we began socializing last Friday with our board and our leadership, and we're going to continue to do that this week, that we are committing to keep our staff whole from a base pay perspective through the end of June. That is a very conscious decision that we're doing because, as Tammy said, we have 500 patients in the hospital right now. Those are not all COVID patients. We're about to reopen. We're going to bring more volume back. So we're going to need our staff to be ready to take care of these patients and do the great work that they always have done. We're also allowing our staff to do some other things. We've assigned 50 of our staff to be contact tracers for the state of Kansas. We are trying to do everything we possibly can to allow our staff to stay busy, to stay employed, and we're going to secure those folks through the end of this fiscal year.
That is such great news, I know, for our team. And Tammy, when you think about bringing people back, what are some of the steps we're taking to think about increasing our patient volume, open back up?
Well, I think we'll be very cautious and very deliberate in how we do that, and working with the physicians to decide which patients need to come back in. As I mentioned, and everyone knows, many things were put on hold or on pause. There are some patients that we know need to get back in, so the physicians will help determine the patients that we need to get back in from a procedure standpoint, from an operating room standpoint, and then we'll be working with those patients. Many of those patients will test before we bring going back into the system. I think that you even have someone coming on later this week to talk a little bit more about testing of those patients. So that's one thing. You know, one of the things I wanted to mention, Bob talked about our staff and how we're working to always make sure we're taking great care of the people who are taking care of our patients and supporting those who are doing that. And we know that some of our staff aren't quite as busy right now. Their areas aren't as busy. And we also know people want to be busy. They want to do good, meaningful work. And so what we're doing is also redeploying some of our staff to areas that have more work to be done. So I mentioned the screeners at the front of the hospital or at many of our locations, but we also have people who are totally changing what they're doing to help our hospital become prepared for taking care of patients, more patients, and just to make sure that we're doing what we can to keep our environments clean. We have some of our sports medicine staff who are coming in and helping in our environmental service department, making sure that the handrails are clean and that we've got the chairs cleaned as often as we can during the day. Those are pretty remarkable.
They are remarkable, and I know it is incredibly important. There are some articles that have been published over the last few weeks talking about the increased rate of death in our community for patients who aren't getting care but are having heart attacks and strokes at home. And I think there's a general fear of hospitals. Folks need to know that hospitals in general, and I know we work so hard at patient safety, including in the COVID era. One of the things we're talking about doing before people come to have surgery is to always have a COVID test before you do, because we do know that patients who have COVID disease and have surgery are at a higher risk of a bad outcome. So before you have surgery, you get a COVID test. And before you come, and anybody who comes in the hospital with any suspicion at all, we'll do a COVID test on. And we have outstanding, I think, PPE precautions that are trying to keep folks safe. I think it's really important for us to say that at least and we do a lot of active surveillance, we've not seen a patient-to-patient transmission within a hospital or a staff-to-patient transmission of COVID-19. Now, I don't know if that'll always be true, but we really work hard at that, about trying to make sure patients stay safe. Dr. Hawkinson, you're out there, I think. Talk to us a little bit more about some of the things we're doing in the infection control world to keep our folks safe.
I'm here. Yeah, hi. We've been working with infection prevention and planning for all of this stuff. When patients come in, not only with COVID, but any other new emerging infectious disease, to take precautions and have protocols to keep our healthcare workers and our patients safe. So we do that by making sure that we keep up with guidance from the CDC and other public health entities, such as Kansas Department of Health and Environment. And those are really helping to put in the systems. In addition to that, we keep very good information on how much PPE or personal protective equipment we have, so that we can really arm our healthcare workers with that, so that they have enough. Currently, we seem to have enough, as Tammy had talked about. So we are doing, along with the protocols, it's a matter of testing, identifying cases, making sure the cases were put into proper isolation, and all of those types of protocols and policies were followed. Number one, from the minute you step on campus until the minute you leave, we are continuing to do those things.
I think it's also important to note, even as we talk about having patients come back or increasing our volumes a little bit, it's really just kind of dipping the toe in the water. If you look at our operating rooms, we're talking about doing cases that we can do with regional blocks and not general anesthesia, because we know that general anesthesia supplies across the country are low. And in the clinics, we're talking about half of our volume, so we make sure that patients stay safe in the clinic, that the staff stay safe, and everybody can appropriately distance. So I think we've done a lot to take care of that.
One thing that we'll continue to do is limit our visitors. That's really hard, and we know that, and that's been hard for patients, it's been hard for families, it's been hard for anyone who typically would come to visit patients in the hospital. But I will tell you, I think our staff has just done a remarkable job connecting patients and families virtually. They've done it, they've done Zoom calls with multiple family members so that the patients in the hospital can connect with their family, and they do what they've done always, which is really connect with patients and take great care of them and meet their needs. And that's what our team will continue to do. It's harder when they can't have their family in the hospital. I know that, and it's probably so much harder on the family members sometimes, because the patient is being cared for by our staff and our physicians, our nurses, our therapists. I think they do a really remarkable job. We've gotten a number of notes and cards from patients and families just thanking our teams for all they do and for helping to really fill that gap when the family members can't be here.
Bob, you always talk about swimming upstream. I think that's a great analogy for us.
Well, obviously, there's a lot of concern about safety around COVID-19. I have to tell you, about 3 or 4 years ago, we got into our initiative around zero harm. That had really nothing to do with COVID-19. That had to do with our absolute expectation that no patient should be harmed when they come into our hospital. So I want everybody to understand that in the midst of this crisis, we have not let off on the pedal in terms of our zero harm scorecard and our zero harm surveillance. So we're continuing to monitor every hospital-based infection that comes through. We're continuing to see those numbers on a weekly basis, and we're continuing to drive that volume down. So I just want people to know that we still have that fundamental principle in line here with our organization. As far as swimming upstream, Steve, I think that's what we've done for 21 years. I mean, 21 years ago, there were pundits that said we should close or sell. Well, we didn't do that. Right? And then when we brought our medical staff together, we did the big bang. We didn't just decide we were going to do it piecemeal over time. So we've never taken anybody's playbook off of their shelf and tried to put it in place here. We've created our own playbook, and I think that's exactly what we're doing right now.
Yeah. So I suspect there are questions from our media out there. Good morning.
Good morning. This is Shannon O'Brien at Fox 4. I'll jump in and start. There was an article in the New York Times over the weekend, and it showed a conversation between a lot of the different mayors in Kansas City talking about basically how public pressure may cause them to open sooner than they're comfortable and sooner than the health departments are suggesting. Could you please give us your medical opinion about opening too quickly? When should we open? And have we hit our peak yet?
Wow, that's like the 60 million or 60,000, I don't know, whatever the 60 is, question out there. And I'm not sure that there's a really happy answer to that. Meaning, and what I mean is that whenever we open, unless we actually have effective therapy or we have vaccinations or both, there will always be risk at reopening society for increased spread of the disease and bringing about another surge. Ideally, the way you avoid that is having such widespread, easily accessible, and rapidly returnable testing that you're able to know when someone's sick so that they can self-isolate or stay isolated at home. We don't have that yet. On the other side of that is all the economic pressure, and I'm not a politician, so we try to stay out of that lane. But we recognize it and feel it every day. And we feel it also when there are patients at home not getting care. I think that from a pure public health standpoint, if you just isolated the question and said, when's the safest time to go back out into the public, just from a public health standpoint, and you left the economic and the other patients who are struggling and not coming to get care and all those other things, you left all that over on the side, and you just said, from a public health perspective, when is the right time? The answer is when you have vaccinations and therapy, or at the very least you have really adequate ability to test for who's got it, who's got contact tracing, and that you can measure who's been infected, that is the antibody testing. Well, of all of those, we can do contact tracing increasingly because we have all these volunteers, like people from the health system coming aboard. testing's ramped up, but we don't have enough tests to do community-wide surveillance. The problem is when you only test people who are sick, you just know who's sick. What you don't know is what's the overall prevalence of the disease in the community and how many people are being infected and where are the rises and falls in those numbers. And that leads to different interventions that you can make. So I think what we're seeing, and we're not just seeing it in Kansas City, it's true across the country because the pressure exists there. In fact, it's true across the world. There is a need for people to be able to go and do their jobs, and there is risk inherent in doing that. And what we are deciding as a society, I think, is that the risk inherent with going out and being in public is starting to outweigh the risk of getting COVID-19. And part of that's because we have done such a great job in the metropolitan area of bending the curve and flattening the curve and seeing a low level. Yesterday, our census was 25 patients with COVID-19. You know, we've been between 20 and 30 now for 2.5 weeks. We really haven't seen another surge coming. We live a little bit in fear, I call those COVID dreams, of a surge that will be like what we saw in New York City. What we have to do when we reopen is to go out and practice all the same things we've been doing all along. You can do a really good job if you maintain that 6 feet of distance, you wash your hands, you don't touch your face, you wear a mask when you're in public if you're going to be in contact with others, and if you're sick at all, you stay home. I don't know, folks, any other questions?
No, I think that's exactly right, Stephen. You've been saying this every day. I think we've been trying to make sure that everyone knows these practices have to be in place. We can't let up on the practices that we know have really worked. That social distancing and making sure that if you are sick, stay in, stay home. Don't come to work. Don't go out in public. The wash your hands. That's just been something that healthcare providers have known for years. That's the right thing to do. We've been monitoring hand washing compliance for decades, and those are just important things for us to always do. And I think those practices can't be put to a side. They have to be front and center, as particularly I think as we start to reopen a bit.
And I think you're right. We have been saying, in fact, every day. And so if repetition is the heart of learning, I think we've done a lot of education.
There you go.
On the same point. Dana, anything else you'd add to that?
No, that is exactly right. As we start to ease these restrictions, it's going to be more and more about personal responsibility. And so it's our job as healthcare providers and educators to get that very simple message out to the public and continue to reinforce that so it becomes like second nature.
And here's the fear, right? This is the fear. We start to open up society. People don't do all the measures. We begin to see a surge. Folks get scared again when all of a sudden we're getting kind of a lot of patients, and then you have to start closing society. And that, I don't think we want to see that. So, you know, if I had my Harry Potter wand with me, we would have those three things, the test, the therapy, and the antibody measures. And that, I think we would be able to stay safe. Short of that, we're relying on everybody out there to help keep us safe. There's no one person that can do it. It's actually every person doing it that will keep us safe. And it's following those same things you hear us say all the time. Next question.
Need to reopen society May 1st, May 3rd, or May 15th, or is all of this just because, well, it's going to happen, so here's what you need to do to stay safe?
We're not ready. She just said that.
So I think it's what we just. I think it is kind of what we just said. I don't know when the date is until there's effective therapy, and we can measure antibodies, and we have a lot of testing available. Whenever we open, it's a calculated risk. Which side of the calculus you want to stand on? You know, here in healthcare, we have this view of what the risk is. It's our view. It's our lane, and that's what we try to stay in. But you know, there's nothing short of a magic wand that's going to make it completely safe when we go back out in public. And there's nothing short of personal responsibility that's going to keep us as safe as we can without those three things. Irregardless of when you open, I did that word again, regardless of when we open back society. Next question.
One for Dr. Hawkinson, if I could. Given the statistics we've seen out of the Johnson County COVID dashboard, something like 92% of the fatalities being age 70 and over, 67% age 80 and over, do we have now a broad public health crisis, or are we looking at a geriatric health crisis?
Oh, that's a great question. Dr. Hawk.
Yeah, I mean, as far as the statistics go about age of higher risk of critical illness and death, this is really consistent with what we've seen since the initial days of the reporting from China. We have always had concerns about the older population for sure, and that's why we also continue to have really good contact. And we had Dr. Calendar Rich on Friday for the nursing homes. We know that those populations are generally going to be our most at-risk populations for critical illness and mortality or death.
I would also be very careful with statistics like that, because you have a small number of deaths and you have to think who's being affected so far, who's the vulnerable population. When we sheltered in place, a lot of younger people stayed home. When we sheltered in place, the nursing homes, well, let's see, they haven't changed their environment outside of no visitors. And what's happened is a lot of those deaths have come from elderly populations in nursing homes or the post-acute care units, things like that. And so when you do that, you sort of, when you got a small sample size, sometimes you have to be a little suspicious. Let's come back in a year and then let's revisit what the statistics in Johnson County look. But as Dr. Hawkeye said, across the world we know that older folks are vulnerable. Yes, it is probably a geriatric population that is most at risk because we have, oh man, I just put myself in that. I just said we. Because we have more health problems in general. But anybody with underlying health problems can have that same effect. And remember, there's still a significant number of otherwise healthy 20 and 30-somethings who are dying from this disease. It's a different kind of death, meaning that they have a little different disease trajectory, a little different presentation. But COVID-19 is a threat to everybody, not just the elderly. Next question. Not hearing one, I get to come up with one.
I think we have some. Dr. Stites, this is Nate with the health system.
There, Nate, I was waiting.
Somebody asked earlier about what our full capacity, because they heard that we have 500 beds. So what is our capacity? And they also want to know, what are we doing with semi-private rooms? Are they now just having one patient per room right now?
Two great questions, Tammy.
Sure. You know, our typical census on this campus most days would be somewhere 750, a little bit higher than that many times. So we have 500 patients in beds right now. So no, we're not using any semi-private rooms. We never wanted to use those, and just because of capacity issues, there would be times that some patients would be in semi-private rooms. So I think that answers your question. We're not using those today, of course, and would like to not use those, but until we have additional capacity at some point down the road, we'll still probably go back to those at some point, but not right now. We don't need to.
And they, just to follow up on that, is I want to get back to this point about don't get too sick at home. You know, we do have some capacity, and part of it is, you know, we haven't been doing as many surgeries, and especially we haven't been doing surgeries where we think it's a little riskier and you're going to have to be in the hospital unless you need it. We'll do that, but the semi-elective surgeries we've tried to not do. And the same thing has been true for seeing new patients in clinic. All that can generate hospital admissions. But I think we're all a little nervous here about people having heart attacks at home. You know, Dr. Dendy was here last week from cardiology and described his fear, and it's reflected nationally that people are having not the really big, crushing, terrible heart attacks. They're coming to the emergency room. That's the same. But these kind of small heart attacks, which can add up and cause significant damage, those are the things that people aren't coming to get help for. And so they're thinking, oh, I'm a little short of breath. I've got a little chest tightness. Maybe I moved, or I did something wrong yesterday. You know, you got to take care of yourself. Otherwise, you put yourself at more risk for COVID-19. It's not coming into the hospital that's going to put you at risk. It's getting sicker at home that's going to put you at risk, because then you're not able to handle the infection if you get it. Plus, you don't want to have a stroke and have the side effects and have the permanent deficit. We can intervene and do stuff. So whether it's KU or Shawnee Mission or St. Luke's or wherever you go, get your care. Don't stay home and just get sicker, because that, again, that'll make you more vulnerable, not less. Nate, another question. Anybody else?
We have some people who are asking. I think you've just been talking about elective surgeries, and so somebody was asking when we think we might allow for those again, and we had somebody else that was asking about IVF cycles, because I think those have been put on hold for now.
Yeah, those have been put on hold. So do you want to kind of outline our timeline a little bit as best we can? I mean, it's a little fluid because
Sure,
we
it is, and we're working with the physicians. I mentioned earlier that it's really important that we work with the surgeons to identify which patients do need to come back in, and we'll do this in a really gradual, slow way. You know, we know that anything we do needs to be really thoughtful. We need to be methodical in our approach to this, but I think we'll start to see some additional cases even this week in our operating rooms, and that's working with the surgeons. Dr. Stites has been working with the surgeons to identify the patients that need to come back in first, and the ones that, as he mentioned, won't need general anesthesia, but rather regional blocks, and I think that's really important, and we'll take it slow. You know, it's that small test of change to make sure that when we do have a little bit of a change, that we're monitoring everything from medications to our PPE to make sure that we have what we need when we need it. And so I think it's working with the surgeons, and the surgeons will be working with patients directly to identify those who should come back in as early as sometime this week.
And I think on the other side, in the ambulatory space, it'll be a different type of clinic visit than you will have had before, because we're trying to keep the waiting room pretty empty. And I think the way it'll work is you'll get a text when it's getting close to your appointment, and you'll come in and go directly to the exam room, where one person will come in and do your vital signs, look at your medications, and then you'll see the physician and the nurse, and then when you exit, you won't get your appointment. You won't stop at the desk again. You'll just keep going back to your car, and you'll get a phone call to reschedule your next visit. All of that is done to minimize any chance of patient-to-patient contact, or make sure we maintain social distancing and things of that nature. So we've really thought very closely about how we want to do the ambulatory visits. We're doing the same thing about the operating room, making sure people and staff stay safe.
I think it's also important to note that our telehealth visits will continue. We've done many thousands of telehealth visits, and patients like those, that's great for a number of reasons. But certainly it's easy, it's convenient. They can have that visit from their home. Those are really important, and we'll continue to have those visits in addition to bringing some of those patients back into the ambulatory areas, the clinic areas, because they need to be seen face to face.
The telehealth thing is a crazy good story. You look for silver lining in crises like this, and really that's it. In fact, Keith Sale will be on our news time brief tomorrow to talk more about making sure patients get in to see their physicians and the impact of telehealth. I think we used to see 4,000 to 5,000 patients a day in all our outpatient sites, and I think on Friday we got up in around 3,800 combination of inpatient and telehealth visits. A lot were telehealth. Wow. So those guys have done a remarkable job trying to come back. Other questions that are out there?
Do you want to talk about any of the new symptoms that were just announced by the CDC? And somebody was also asking about antibody testing. Are they reliable?
Yeah. Dana, you want to take that on, especially that antibody testing?
Yeah, we can start with the symptoms. Certainly that we have known that symptoms, for the most part, original reports were fever, cough, shortness of breath. We've all heard of that. As we get into more reports in different countries having different experiences, especially in the United States experience, we are learning and have good reports of other atypical symptoms. Those range from just feeling bad, malaise, or having muscle aches or myalgias, to other things such as diarrhea. Also, we've talked and we know about the lack of taste or lack of smell. So these are very atypical presentations, and we've been going through those, and we've kept up with the guidance. Even for our employees and our checklists, we have put those in our employee when we're screening for symptoms of illness, when people think that they are ill, to see if they can get tested for COVID. So we're really aware of those atypical symptoms and presentations. The other thing, as far as antibody testing, yes, we absolutely need that. We have been talking about this for weeks. We really need to get a reliable test. We have our excellent lab services with Dr. Leisman and Dr. Plapp, who are working to find and validate and vet a very accurate serology or antibody test so that we know if we test you and it looks like you've had a positive test, that you've actually had exposure or infection with COVID-19 and not some other common human coronavirus that causes just a typical cough or cold.
New Jersey was starting to use salival testing for COVID, not the antibody testing, but for the PCR. Any comment about that? Because that would certainly be nicer than the brain biopsy.
Absolutely, and Dr. Leisman has been working with that for the past 3 or 4 weeks, wanting to get a validated test for that, because it definitely would be much more simple for the person getting the test, but for also the person giving the sample. So that is something we continue to work on and evaluate on a day-to-day basis to find the most rapid, accurate, and least invasive test as possible to diagnose acute infection, but also a past exposure. So we are looking into working with that kind of test as well.
Yeah. Other questions? Nate, anything else from your standpoint?
I do. I have a woman who has a physician's appointment scheduled at the main campus in June, and she is scared to go there. She already doesn't like crowds, but she's also immunocompromised. And she said that when she called about a telehealth appointment, she was told they weren't doing it in June.
Let's clarify that. Yeah. No, so I think what that means is we've not. That's a great comment, and I appreciate hearing that. We haven't built out the telehealth schedule for June yet because we're trying to see what the relationship will be between in-person visits and telehealth. We will be doing telehealth forever. This is not going to go away. The thing that made it easily accessible were changes in guidelines from the government about our ability to use different vehicles for telehealth. And because they opened that up a lot, it really helped. Now, just so you know, when they did that, they said that's for the COVID-19 crisis, and we may go back to the old world. If you have any political pull out there, folks, try and encourage your legislators not to pull the plug on the telehealth thing. That's been like the most important thing that's come out, I believe, from this crisis. So, to the point for that patient, as they build the schedule, you are going to be able to do a telehealth visit if you want. That is an okay thing to do. So I see patients in my clinic with that are post-lung transplant and who have cystic fibrosis, and so also a very highly vulnerable patient population. And we think there are some of those folks we just need to see in person. And again, we've tried to design the ambulatory visit now. It is different than what you've experienced before. So if you think, well, I'm going to go back to the same way it was when I came into the clinic, that's not how it's going to be. It's going to be a different type of experience. We're trying to get you out of your car directly into the room really quickly. I've had a few of my patients come in. We've done a few visits. They're like, oh my gosh, this is so different now. Even the lab is just streamlined because we do that differently. So I think it'll be a lot safer from a COVID-19 perspective than anything you will have experienced before. And I suspect most clinics around the city are trying to do the same thing. But if you want to have a telehealth visit, we will be able to do that. And in fact, in the same half day, some of my visits are going to be in person and some will be telehealth, and they're all just mixed right in there together. My best guess is we're going to end up in a 50-50 split. I think that's going to be a long-term thing, and especially when you look out across the city and across the region and into western Kansas where there's so few specialists. I think this telehealth answer is going to be just great. So I think we're looking forward to that. I think that patient will be safe. We'll keep you safe.
About it tomorrow too.
Yeah. Keith Sales, I mentioned, he'll be here tomorrow for the telehealth stuff. So it'll be good.
And Nate, I think you mentioned that this individual doesn't like crowds. Well, I'll tell you, I was thinking of this when I was walking in today, that our lobby used to be one of the busiest places in Kansas City, that we just had a lot of people coming and going all the time. We've really restricted the number of people in our place, so it's different. It's that new normal, and I don't think that you will walk through our lobby anytime in the near future for people to have an entire lobby filled with people. I don't think we'll have that because we're restricting visitors. We're gradually bringing patients back in. As Steve said, they'll be called so that they can come in and go directly to the room, not to a waiting room. So a lot of things are changing.
Yeah. Any other questions out there before we wrap up?
I always think it's good to talk about the community and the support. And Bob, you've had a lot of people reach out and just want to support our place. And I think they're supporting healthcare across the city.
Yeah, the reach outs have been phenomenal. And whether those are through our sports partners, the Chiefs and the Royals, or whether those are some media celebrities or some entertainment celebrities, we've been able to get videos almost every day, these inspirational videos that we've been able to share with our staff, which have just been so well received. We've got reach outs from folks bringing food in. We've got corporations that are providing free food. I mean, it's one of those moments. I'm not from here. I'm a Chicago boy, but I'll tell you, been here since '96, and I love this community because I've never seen a community rally so much when times are tough. And this is one of the toughest times I've ever seen here. And the community outpouring for our organization and every healthcare provider in Kansas City, I think, is just a testament to what a great community we all live in.
24 years is a long time. I think you can say you're from here now.
And don't you think, Steve, it's sometimes it's the small thing that just makes such a difference. It's the signs that are up that I think the churches have been putting out that just means so much to our staff.
It does. It feels good.
And it's the little notes that people have received. And I think sometimes people think those are pretty small. Those are big deals.
Yeah.
We do those internally for one another, and we make sure that our teams know how much they're appreciated. But I think the community has just done a really remarkable job supporting healthcare in Kansas City, not just at our place, but across Kansas City.
Any other last-minute questions? Dana?
Yes, I actually had a woman. Let's see. She says that she's considered high risk, or she wants to know if she's considered at high risk because she's had breast cancer last year, and she had 20 rounds of radiation just finished in June, and has been on tamoxifen for 5 years, and in November had a clean mammogram. So she just wants to know, is she considered high risk?
Dana, what are your thoughts about that?
Yeah, I think that it sounds like she's gone through the majority of her treatments. Certainly her age, we have to consider that. I think just in her past with the breast cancer and the radiation and her other treatments she may have gotten, I don't know that the tamoxifen necessarily leads her to being into a higher vulnerable population, but certainly with age and that would be probably the biggest factor at this point in time.
Yeah, I think as you've finished your therapy, your risks go down. Age and just any comorbid illness still maintains a risk factor. I also forgot to answer a question earlier that was about IVF, and we have not decided on the date for reopening the IVF clinics. That's probably the one part of the staging, and it'll come, but we'll turn to our IVF specialists and Dr. Weinecke, chair of OBGYN here, to help us determine what the right date for that is, and I don't know that otherwise right now. So guys, as we kind of think about reopening, what do you all look most forward to doing again?
That question has been asked a few times, and clearly getting together with family and friends, those are things that we all want to do. But I miss sports, and I miss going to the theater. I miss seeing some plays and musicals, and I love the arts. So I'll look forward to both of those at some point in time. But most importantly, it's family and friends.
It is. Bob?
Yeah, it's always hard to follow Tammy, right? I mean, those are apple pie answers, and I have the same thing.
I mean, she is, because it's true.
I love sports, and whether that's going and watching the Royals or whether that's actually going to play golf. I had surgery a couple of weeks ago, so I'm still on the mend, but I have 4 weeks to be able to get back out there, and I'm ready. I just don't know if it's the right time to do that. But anything sports related, I totally miss that, and I miss family and friends. And had a new house we moved into in November and really can't entertain, so that's really hard. So
yeah, Dana.
No. Nothing else to add. We unfortunately missed the Jayhawks raising the national championship. So I think once that went away, it was kind of certainly more sad for me. But we still have some summer stuff. MLS hopefully can start going. Sporting, we can get Sporting into the playoffs and get them bringing home another championship as well.
It looked really good to start the year before it got shut down. They're off to a great start. I think all those things. Then every Saturday I like to go by K&K Fly Fishers, hang out and tell fish stories, which are maybe not always totally based in truth. And so we can't get back to. I know it's a shock. Maybe just a little exaggeration on that one. So anyway, well, thanks for being with us today, folks. We'll be back here tomorrow with Keith Sale, and we'll be kind of addressing how we're going to be safe in the clinic and how telehealth will be our ongoing vehicle for many of our folks. So thanks for being with us today. We'll be back tomorrow.